To the 21st question. 75 years old female with rheumatoid arthritis present to your clinic with the complaints of long-standing elbow pain. She has 20-degree flexion contracture. On examination, pain diffusely about the elbow. There is a soft tissue nodule noted to be overlying the elbow. A radiograph is seen in the figure A. This is the radiograph provided. Which of the following is true regarding the development and management of the most likely pathologic prognosis? So there is flexion contracture. There is nodule. There is soft tissue nodule. So it will be a rheumatoid arthritis. So the answer would be proteoglycan and collagen destruction. So rheumatoid arthritis of elbow is caused by pathologic pannus formation leading to hyperplastic synovial proliferation and subsequent collagen and proteoglycan degradation. There is pannus formation, synovial hyperplasia, degeneration of collagen and proteoglycan. Chronic synovitis, ligament attenuation. So semi-constrained implant is needed for total elbow arthroplasty, and X-ray will show periarticular osteopenia, and there will be contraction of the elbow. 60 years old diabetic man present with increasing right shoulder pain, stiffness for 10 weeks. Not improving with the NSAIDs. He had previous history of injury 15 years ago while playing hockey, and significant reduction in shoulder range of motion is present, and there is greatest loss in external rotation. So it will be an adhesive capsulitis which shows greater loss of external rotation. The treatment is physical therapy and medical management. Adhesive capsulitis, physical therapy and medical management is the appropriate treatment. Is also known as frozen shoulder. Pain and loss of both active and passive motion, especially loss of external rotation in comparison to the contralateral side. Risk factors very important: diabetes, thyroid, previous surgery, prolonged immobilization. Initial treatment will be NSAID, physical therapy, and radicular steroid injection. Surgical treatment is recommended but may be used late in the course at residual stiffness if extensive therapies failed only. So this is the sagittal section of the MRI showing coracohumeral. This is a rotator interval. This is the coracohumeral ligament. Coracohumeral ligament thickening is shown, and this is the coronal section showing coracohumeral joint thickening or rotator interval fibrosis. Next question. A weightlifter feels a pop in his anterior left shoulder while doing a bench press test. Bench press is very prone for pectoralis major tendon rupture. This is the pectoralis major tendon. This is the biceps tendon. This is the medial. This is the bicep groove. This is the medial eminence. This is the lateral eminence. So biceps is avulsed from the lateral eminence of biceps groove, which is supplied by lateral and medial pectoral nerves. So images showing the retraction of the pectoralis major muscle, which is most commonly injured in bench press, in bench press exercises. So we have to repair the biceps tendon to the lateral part of the biceps tendon. Hip arthroscopy complication, most commonly related to which of the following? Use of traction. Use of traction is the most common cause of complication in hip arthroscopy. Hip arthroscopy transient neuropraxia can cause to the pudendal nerve or peroneal nerve. Pudendal nerve groin and the peroneal nerve dorsum of the foot. The indications are loose bodies, labral tears, chondral injuries, avian synovial disease, ruptured ligamentum teres, impinging osteophyte, and unexplained mechanical symptoms. So early reverse total shoulder design before the development of Grumman style processes had a high failure rate due to early loosening of the glenoid component. What biomechanical feature account for this problem? So glenoid component, central rotation 2 inferior, humeral component 2 inferior, glenoid component did not have a neck. So, but the answer is center of rotation 2 lateral. This is the answer. Center of rotation. So there is an evolution of reverse total shoulder arthroplasty. Reverse shoulder arthroplasty initially was the glenoid component was kept lateral, too much laterally. So there was too much lever arm to the glenoid component, and it was remained lateral to the scapula, which limited motion and produced excessive torque on glenoid component, leading to early loosening. Then Grumman introduced two major innovations, which is a large glenoid hemisphere with no neck. So it will be medialized, and a small humeral cup almost horizontally oriented with a non-anatomic inclination of 155 degrees with covering less than half of the clinosmere. So we have to understand the Grumman's modification. So it led to the improvement in the biomechanical property of the RSA. Which of the following patients most likely to have a fibroblastic proliferative process as a cause for their shoulder complaints? So it is definitely fibroblastic proliferation is seen in frozen shoulder or adhesive capsulitis. It is most commonly seen in women. Hypothyroid. It will lead to both loss of both active and passive motion. Adhesive capsulitis, fibroblastic process. This is idiopathic. Females 40 to 60. Diabetes, hypothyroidism, coronary artery disease. It will lead to reduced capsular volume, pain, global loss of motion, loss of both active and passive motion. That is very important. Loss of both active and passive motion. This is the arthroscopic image showing fibroblastic proliferation in rotate interval. So 27th question. This is a very important question. It's characterized by hypothermia, central nervous system dysfunction, and loss of thermoregulatory function. This is heat stroke. Heat stroke is a medical emergency. It's a medical emergency. Cessation of sweating, hot, dry skin, central nervous system dysfunction, hypothermia greater than 105.8 degrees Celsius is a medical emergency. Failure of thermoregulatory mechanism, high death rate, and requires rapid reduction in body core temperature. A 55 years old male patient present with right shoulder pain that is worse with overhead activity. Overhead activity, we have to remember glenohumeral internal rotation deficit, posterior superior labral tear or slap tear, and also internal impingement. These are the three most common consequences of overhead athletes. Recreational swimmer has noted worsening with pain in breaststroke. So in MRI, we can see that there is a hyperintensity in the superior labrum. So it's a slap tear. So slap repair in patients older than 36 years has got a very poor prognosis. In older patients, we have to go for a biceps tenotomy and tenodesis in this age group. We can do it either arthroscopically or open. And we have to know about the types of slap tear classification. This is the Snyder classification. Type 1 shows only fraying. Type 2 with the fraying plus detachment of the biceps hanger. Type 3 is the bucket handle. Type 4 is the bucket handle extending to the biceps tendon. This is the Snyder classification. Next, 29th question. The 12-year-old male has an immediate pain and ecchymosis over his right groin after injuring himself during hockey game. This radiograph is shown in the figure A. Which of the following statement is true regarding the insertion of his injured muscle? So here we can see an avulsion fracture. This is anterior superior iliac spine. This is the anterior inferior iliac spine. Here the avulsion fracture is in anterior superior iliac spine. Anterior superior iliac spine attached structures are transophageal lata and sartorius. Anterior inferior iliac spine is attached to rectus femoris. So tendon is. So this is sartorius, and it can be a cause of pus anserinus bursitis also. So the answer is pus anserinus bursitis sartorius fascia, which is attached to anterior superior iliac spine. Sartorius and transophageal attached to anterior superior iliac spine. It is a cause of painful bursitis. So we can see the picture showing iliac crust, which can cause avulsion fracture of abdominal muscle, anterior superior iliac spine, transophageal lata, sartorius, anterior inferior iliac spine, rectus femoris, greater trochanter, attachment, hip rotators, LT is attached to iliopsoas, which are flexors of the hip, ischial tuberosity, which is attached to the hamstrings, and body of pubis and inferior pubic gramina adductors. Adductor strains are involved in adductor tubercle, not in abductor tubercle, the pubic symphysis. This is the image showing rectus femoris avulsion in anterior inferior iliac spine in this area. In the last question, 62 years old female with history of rheumatoid arthritis person with end-stage elbow arthritis. Regarding total elbow arthroplasty of rheumatoid arthritis, which of the following men survival would be expected? Rheumatoid arthritis patient with total elbow arthroplasty has a very good survival results at 15 years. Very good survival at 15 years. There is in elbow arthritis, in rheumatoid arthritis, there will be attenuation of the ligaments also. So semi-constrained total elbow arthroplasty should be used in rheumatoid arthritis patients.